Hi everyone, welcome to the Ypsilanti District Library. Thanks for coming out tonight, and I'd like to also thank our panel of, are you all from the, oh actually I say different departments, to our program, Bright Nights, this community forum we have on understanding bipolar disorder. And join me in welcoming Dr. Josh Bess, who will be heading tonight's presentation. Thank you.
Thanks. I think what we can do is I can go through some just basic information here, and then we can introduce the panel. I'd like to leave lots of time for questions, because I think that that's mostly what people come for. But it's nice to have a little bit of background and hear kind of a little bit of a presentation. So that said, one, if you can leave questions at the end, you'll have plenty of time. And two, the index cards that were on your seat with the little pencils are for questions. So we'll have you write down any questions that you have. And then when we're at the question part, our folks will be picking those up for you. And that way we can maybe group some questions together and make sure that everybody's questions are answered. So this is Bright Nights, part of the outreach, community outreach of the Depression Center and the Packard Bipolar Fund. This is the first time I've done one of these, so bear with me if there are any glitches. We're going to talk about bipolar disorder. Just a really brief history introduction. There are books and books and books written about this. As long ago as ancient Greeks, Arrhenius of Cappadocia recognized, people knew about or talked about melancholia, depression as we know it, for a long time. He recognized that melancholia and mania were two different things, but perhaps the same illness. They could happen in the same person. And that also mania can be euphoria, can be completely up, but other people would display furious rages. And that basically hasn't changed in the 2,000 years since. Kraepelin, around the turn of the century, when we didn't have as many active, say, treatments as we do now, and psychiatrists and other people would really just observe people in the asylum for months and months and months, came up with this idea of affect, which is our outward expression of emotion or interacting with the world, having three components: volition, emotion, and intellect. We talk about your energy or your physical being, your emotions, whether you're happy or sad, how you're feeling, and then intellect, not how smart you are, but really just your thoughts, your cognitive processing, the rate of your cognitive processing, and how in bipolar disorder, some celebrities with bipolar disorder, this is by far not an exhaustive list. A couple of people that you may have heard of, Sylvia Plath is an author who's in part famous because of her illness and succumbing to it. There are lots of other people you may be aware of. In terms of affect, that may be a little bit hard to see, but in bipolar disorder, the affect, or the mood, as we say, cycles. And what Kraepelin told us was these three things can cycle separately. The volition, or the energy, can cycle, your emotions can cycle, and your intellect or your thought processes can cycle. And they can happen independently of each other. Oftentimes they go together, but they don't have to. This is a normal, quote, normal ups and downs. It's very typical to react to certain things during your day or during a week with some down feelings, some up feelings, but unless you're suffering an episode of illness, usually you're plugging through your day, you're getting things done that need to be done, and you're living your life. And these ups and downs are a perfectly normal part of the human experience. Depression, as you may know, is when all the things are depressed or lowered. This mostly, we talk about the feelings, the emotions, but this can also include the volition or the energy and the thoughts. And so people who meet a lot of the criteria for depression that are listed in the psychiatric textbooks, they have very low energy, they feel perhaps that their thoughts are slowed down, or they can't think clearly at least. The content of the thoughts can also be very depressed and negative at times. And so the whole system gets pushed down. Mania, which is in some ways the opposite, is when the whole system is pushed up. So people can have a lot of energy, a lot of volition. In plain euphoric mania, they may feel great. The world is their oyster, so to speak. Thoughts are coming quickly. They may have lots of great ideas, or at least the content of their thoughts is very positive. They may think that this person may think that they're doing very, very well, and it's actually hard to convince them otherwise. And then what we see in the so-called mixed state, and this is where Kraepelin comes in, is that they can go independent of one another. There's a whole set of these that you can see, you can think about. If one of them went up, the other two went down, and then move them around. This is one example that we see a lot, which is volition is up. So if someone has a lot of energy, you might think of it as nervous energy, but yet they have low mood and their thoughts are slow. They don't feel like doing a whole lot. They have low motivation. That can be like an anxious depression. You can think about with the volition and the intellect decreased and the emotion decreased. These are people who are perhaps agitated. They have a lot of energy and their thoughts are going really fast, but they feel really terrible. It's quite a debilitating and terrible condition to be in. These people are suffering immensely. So that's what we're talking about. That's the main thrust of bipolar disorder, is how these things in a given person will be up, be down, be mixed around. In terms of epidemiology, which is the fancy word for how much does this happen or when do we see it, there was a big study almost 2 decades ago now called the Epidemiological Catchment Area Survey, and they've done some follow-ups. This is the major epidemiological survey in psychiatry. From that study and other estimates and other studies roughly correlate, plus or minus some margin of error. The lifetime prevalence of bipolar disorder is 1.3%. So a little epidemiology lesson, we talk about prevalence and incidence. Prevalence is how much it happens over the course of a lifetime. It can be over the course of another discrete period, but it's 1.3% of people will have a diagnosis or meet criteria for bipolar disorder in their life, 1 in 100. Incidence is a little bit different. Incidence is how many people may be in an episode right now, and those are going to be different numbers. Bipolar 1 and bipolar 2, which we don't need to get into unless people are interested, split out there. There's well, it's not really a new controversy, but there's a growing controversy and thought in the field that there could be people who have a bipolar disorder or have a spectrum. They go on a spectrum towards bipolar disorder, but don't meet the strict criteria that are in the book. Estimates are that that's a higher percentage. That makes sense, And unlike depression by itself, bipolar disorder doesn't discriminate based on gender. So it's an even split, male and female, whereas depressive illness tends to affect women more than men, depending on the study, 2 to 1, 3 to 1. And in my practice, and I'm sure these folks will back me up, that kind of bears itself out. Genetics is important, especially given the reason that we are here and the work that our center does. The genetics is the information that's passed from a mother and a father to an offspring. And bipolar is considered to be, and these are rough numbers and they mean different things, but 80% genetics. So chances are, if you meet someone who has bipolar disorder, or if you have bipolar disorder, that someone in their family, or more than one person in their family, also has bipolar disorder, or at least some variation of it. Now, sometimes people are adopted, or they may not know. Maybe people don't talk about the uncle that was ill. But chances are, if you did, it gets back there. And as it says on the second point there, having a sibling or parent increases your likelihood, let's say, 5-fold compared to anybody else in the room. So that just tells you what the link is in family relationships, biological family relationships. And then there is overlap with risk and other mood, anxiety, and psychotic disorders. And this, we'll talk about a little bit at the end, but this is a big part of the work that our researchers are doing in the Packard program. Bipolar disorder is often misdiagnosed. You know, I'm focusing on bipolar here. We could very easily give a talk about depression and say the same thing, that people are diagnosed with bipolar and they're actually just depression or something in between. Most of the time, someone with bipolar disorder, when they seek help, most of the time it's for depression. And so if you're meeting a provider, a therapist, or a doctor for the first time, and you say, I'm depressed, they may have every reason to believe that you have just depression. And the bipolar disorder either hasn't declared itself yet, or that's not part of the assessment that's going on right then. These things take time. I often educate patients and families, in psychiatry especially. The specific diagnosis takes sometimes years. You know, some of them we don't know if that's the right diagnosis until other things have ruled themselves out. People often go from clinician to clinician or psychiatrist to psychiatrist without getting the right diagnosis per se. That's not necessarily the fault of the clinician, although it could be. But you know, these things change over time, as we saw. And if you have one person looking one way one day, and then 6 months later they look different, it might be hard to give that diagnosis. Lots of studies have looked at how long it takes to get the diagnosis. In one bigger one, it was 8 years. And those are retrospective. That doesn't mean that the person suddenly was sick and then it took 8 years to figure out what was going on. It's that maybe they had some difficulty, they sought out some sort of help, a school counselor or a religious advisor or maybe a psychiatrist or mental health worker. But it took a long time for everybody to sort out all the information and to be sure about the diagnosis. And if you have anxiety, if you have other symptoms, if you have medical problems, then it's even harder to diagnose. I work in the hospital. I see people who are at the most severe end of both ends, depression and mania, and we're very often not sure. And it's almost as clear as it can be at that point. Age of onset and sort of the course. The classic is in the late teens and early 20s. Being in a town with two big universities nearby, you know, we see a lot of youths who come to attention for the first time in their freshman, sophomore, junior year of college. It can be before that, but it's very common. There seems to be what we call bimodal distribution, so the majority of people will manifest their first signs of illness in this time, but then there's a smaller hump later in life, maybe in the early to mid 40s, and later, and so that's more common than we originally thought. That may be back when people weren't living as long was misattributed to other things that may have been senile dementia or some other thing. And now that people are living longer and we're seeing these folks and they're living very fulfilling lives until bipolar disorder strikes them down at 60, we see that yes, this can happen. Relapse is frequent, and even if it's very well managed, it's still something to worry about. So what that means is, you know, 75 to 90% of people will have more than one episode in their lifetime. Bipolar disorder is the 6th leading cause of disability worldwide among people in this kind of young, what is usually considered sort of a productive, working age population. This is across socioeconomic lines, across countries. All this data comes from the World Health Organization, and it's associated, it's higher on the list than, say, osteoarthritis, HIV, diabetes, and asthma. You know, the only things that are higher are depression by itself, heart disease, cerebrovascular disease, which is stroke. I forget there's one other one in there too. Those are the only things that cause more disability, and they calculate that various ways, but it's sort of an equation of how many years is a person disabled or unable to function, times what their, say, earning or productivity potential is at that time. That's where they come up with this number. It's a very big problem, and it's thought to be actually getting bigger. As we've figured out better ways to treat some of the other things, the proportions are changing. And and maybe moving up the chain. Social impact is enormous. That's actually, and these people will definitely back me up, that's where we spend most of our time. 60% unemployed, so I don't know how much any of you will be keeping up with the presidential election and debates, but people throwing statistics back and forth at each other that, well, since you were elected, unemployment's gone from this to this. Since you were governor of Massachusetts, it went from this to this. Nobody's going to get elected with an unemployment rate of 60%. Okay. The unemployment rate in Greece, which is on the verge of bankruptcy, is somewhere like 30%. Hugely debilitating. That includes college graduates, so people who supposedly were going to make it, who were going to go on and do something with themselves. And then a similar proportion report impaired long-term relationships. We can talk more about that in the questions session. This illness wreaks havoc on families, on partnerships, and other relationships. There's a lot of anger and frustration and sadness and other things that happen to people. The economic impact, I alluded to it a little bit earlier. This is estimated, and this is America now, this is the United States. The cost society 10 to 45 billion. It's a wide range. It's hard to measure. This is lost production, lost work, and also the actual medical cost of treating the illness. Per patient, if they're working, this averages 50 days a week, or a year. A total of 180 million lost work days a year. And they're kind of throwing out this money thing, the $25 billion that people lose in potential income because they're off of work. So if I don't know if anybody here runs a business or employs people or works directly with other people, if somebody's missing 50 days a year, that is a huge deal. And you can see now why so many people are unemployed. Coexisting with substance abuse is very common. We say it's the rule rather than the exception. It's greater than 50%. If you have a bipolar disorder patient and they're abusing substances, and really this is for any substance, all of these things are more true. More suicide attempts, more suicidal thoughts, more seeking help at the hospital, more admissions to the hospital, more violence, more aggressive behavior, and double the risk of actually committing suicide. Huge. Substance abuse by itself is a huge risk factor for suicide. But bipolar disorder in the mix and is a ticking time bomb. Medical conditions that can go with the illness, very common. We can talk more about those if you'd like. Some of these you'll see a side note, this may be more from the medication than the illness. Sometimes it's not clear. Lithium, which is one of the main things to treat bipolar disorder, can cause thyroid problems and kidney problems, and on down the line. But some illnesses like multiple sclerosis and migraine headaches have an independent association with bipolar disorder, regardless of medication. Both of them are in the brain, you can kind of imagine for yourself that there could be some connections there. Other causes of the medical problems, aside from a direct connection, poor diet. When someone is very depressed, maybe they don't want to eat or don't have the energy to fix nutritious food or to go find nutritious food. We hear lots of stories about people who stay on the couch all day with a jar of peanut butter. And it's very sad. Smoking, again, with more so with, say, schizophrenia, but with bipolar disorder, substances of abuse are more common in general, smoking included. Obesity, often from medications. I'll be the first to admit it. Our medications are awful at making people gain weight, and they make people have diabetes and get high cholesterol. And then also underutilization of medical resources. So it's interesting, again, with the elections and all the politics of things. We hear more about the uninsured, these, unfortunately, people seen as undesirables showing up in the emergency rooms or getting government handouts or whatever way you want to spin it. And in a way, it's probably a bigger problem that people who are mentally ill, specifically with bipolar disorder, don't get the help that they need. It's the same argument for that preventive care, not waiting until it's an emergency to go to the ER. So someone who's so depressed that they don't want to call the doctor, or if they may be manic and they don't understand the gravity of the illness, the injury, they don't seek attention until it's too late or until it's very severe. And then the costs just escalate because it's a much bigger problem at that point. You can see this graph is increased mortality, fancy statistical number, the standardized mortality ratio. Basically, 1 would be sane mortality. So bipolar disorder patients, period, regardless of cause of death or their status, have males and females are a little bit different, but 2.5 to 2.7 times mortality rate in any given year. So if you have 100 bipolar patients and 100 people who don't have bipolar disorder, and you follow them for a year, the bipolar patients, twice as many of them will die in that year for all causes. And then it splits out. Medical causes, some of which we've talked about, cancer not so much, and then unnatural meaning accident, suicide, homicide, or undetermined. Now that makes sense logically, but based on what we were just talking about, through vascular disease, cardiovascular disease, and GI problems also higher. Treatment. Now, in my experience, most of the questions or most of the discussion in a forum like this will focus on treatment, and that's great, that's why we're here. Just a quick overview, and this is going to be, 2.5 years of practice and training in about 3 minutes. First decision is how severe is it? That's often decided by where the person is. If they're in the clinic and they have a history that they know of and we catch things early, that's one path. If they're in the emergency room or in the inpatient hospital and things are very severe, they may be there against their will, that's another path. That's the first step. Things kind of go parallel from there. In the office, in the clinic, you can pick one medication and see how it helps, go slow, titrate the dose, watch for side effects. In the hospital or in the emergency room, usually you're using multiple things at the same time. You're giving relatively higher doses to get things slowed down. You may use some ways that we can load the dose, which is to say give the whole dose at once and get the blood level we need in a matter of a couple of days. And then things in between. As far as what the specific treatments are, this is where things get more technical. You can't see that, I'm sure. I can't see either. This is what an algorithm looks like. I mean, there are 100 of these. You can, if you want to look at it more closely, you can go on the internet, go on Google, I think I typed bipolar treatment algorithm, and then if you, on the little bar at the top, click images, you'll see 150 of these. Most of them are the same, it's just different people drew them. We all, in one way or another, use an algorithm like this, okay? In the community mental health setting, it's literally built into the medical chart. In our setting, it's a little bit more loose, but we still all know it in our head, and we teach it to our residents and our students. Basically, what that says at the top, if somebody comes in and they're manic, you give them lithium, or you give them Tegretol, or you give them Depakote. One of those three. This is the first time. Let's say they've never done anything else. And then on down the line, if that doesn't work, you go to this. If that doesn't work, you go to this. If that doesn't work, you add that. Okay. And we can talk about some of those specifics. But that just gives you a little bit of a sense for how complicated it can get. I don't want to oversell that. Our options in some ways are quite limited. And that can be very unfortunate for somebody who's tried a lot of different things. But starting fresh when somebody has never been on anything, there is a lot of good guidance in the scientific literature and algorithms that we have. This is for maintenance, so after we get them out of that acute phase, so let's say discharged from the hospital to an outpatient team, you can keep them on the medication that they're on, keep them on the combination that they're on. Again, they're always looking to say, is this working? Are things slipping backwards? Do we switch to something else? Do we add something else? This is also referring back to other figures, which I didn't include. And then actually, I'll tell you, the most difficult thing is bipolar depression. Bipolar depression is less well understood. In some ways, it's more debilitating. Now, in the ER shows or Grey's Anatomy, things like that, you always see the people who are acutely manic or very disturbed. But that's a very small proportion of time for one patient, and also that's a very small proportion of the patients. People who have bipolar disorder, most of them will tell you most of the time it's quite the opposite. when they're not doing well, that is. When they're in episode, most of the time it's a depressive episode. And if we, again, took that group of 100 bipolar patients, a lot more of them would be in a depressive episode at this moment than, say, in a manic episode. Another truism, and it's unfortunate, and we're all working on it, is bipolar depression is harder to treat. It does not respond as well to antidepressants or other treatments for depression. We have some idea why, we don't know for sure, there are other factors involved. So it's a very tricky situation, and people do suffer a great deal from bipolar depression because it doesn't respond as nicely to some of the other treatments that we have. But we have some information. Lithium again, lithium plus antidepressant, different combinations, these charts go on and on and on. Getting to where we're almost wrapping up, suicide risk, I alluded to it before. Basically, if you look at bipolar disorder compared to any other psychiatric illness, the odds ratio, which means, again, how many times more people will do it, is 6. So compared to a depressed person or a schizophrenic person or something like that, 6 times more likely. There are reasons for that we'll talk about if you're interested. This is just driving home the point, I hope, that this is something that we all take very seriously. I'm guessing that most of you have been either in the situation yourself or a loved one has been, or a friend, where you're deciding whether or not to go to the hospital or to call the EMS or to call the doctor or to get them to the clinic. And this is where we're coming from when we say things like, you need to come into the hospital. No, you don't have a choice, or we need to really do something with your medications today, not next week. This is what we're thinking about. This is, again, it's hard to see. This is a fancy, it's called a forest plot. It's a fancy graph that we use in the scientific literature. But this shows that there's actually a suicide benefit to taking lithium. I'm a fan of lithium if you guys haven't figured that out. So the farther over to the right, the more lithium prevented people from attempting or committing suicide. And then the thing at the bottom of the diamond is when they took all those are all the studies, all different research experiments. The thing at the bottom is combining them all together. And so basically, if the diamond does not cross 0, that means that all those studies squished together show that there's a benefit. Just as a brief side note, there was a study, and there have been a couple of these, but the one I remember is there was a study in Japan where they took samplings of the groundwater in different prefectures, which are like states in Japan, and correlated the groundwater lithium concentration with the suicide rate in that prefecture, and higher lithium content of groundwater, lower suicide rate. They correlated almost in a line. And that's separate from any effect on mood or any other symptoms. So it's almost like it's just an extra layer of armor, so to speak. So in conclusion, this is a category of mood disorders. I left out some slides. We can talk about more details of different specific diagnoses. There's a broad range of severity. There can be a person who has real bipolar disorder who's never seen a psychiatrist, and they can live to a ripe old age. You can have people who are in and out of the hospital pretty frequently. You can have people who, very sadly, don't live very long. It's very treatable. The treatment has to be ongoing, and this is a big problem. There has to be a lot of collaboration between the team, and it says treatment team for a reason, because that's the best way to do it, and the patient, and then, by extension, the family and the loved ones. It's a serious illness. It's a potentially lethal illness. The Packard Bipolar Genes Project is a multi-phase, faceted project that people who do that work day to day can talk more about. But basically, the idea is let's figure out what keeps people well. Let's figure out what makes people sick. Let's get a lot of data, a lot of genetic information about a lot of different people, and then pool it all together and see what correlations exist. And so we have, the eventual goal is to have thousands of samples from people with different diagnoses and different stages of that diagnosis, and to see, is a certain gene more prevalent here, is it turned on, turned off. The very, very large undertaking. I mean, you hear these things with millions and millions of dollars, and that's because it's exactly what it takes. We're tracking participants for 10 years. That's the scientific literature, especially in psychiatry, that's a very long time. Most of the studies that get a drug approved by the FDA, 6 months, a year maybe if it's a really good study. 10 years of tracking, repeated blood samples, interviews, questionnaires, etc. And that takes a lot of people. This information is available out on the table along with a lot of other information, but this is the reason a lot of us are here and a lot of us are involved in this work is the Packard Fund and the family of my instructor. So that concludes the sort of more formal scripted presentation. I am very happy to be supported and joined by a very able panel. So I'm Josh Bess. I work at the UM Hospital on the inpatient psych unit. We have Darren from Montgomery here, who's a clinical social worker, therapist at our clinic. Lindsey Mortenson is a fourth-year resident in our psychiatry residency program. She's the chief resident. And Rendon, who's a good friend of mine, and I've known for a long time, is also a clinical social worker, therapist, and mental health clinician at Packard Health, affiliated with WCHO, CSTS, CMH, on the public side of things. So they are here to help all of us answer questions. If people have already written down questions, we can start to collect some. We'll look at it for a little bit. Take your time. There's no rush. I haven't even touched my coffee yet, so I'm happy to do that. Kat will be around to pick up some of the note cards.
Or you could call it out.
Yeah, we have one
cards where you could just speak.
Well, yeah, so this young lady here has a card.
Sure.
But does anybody have a burning question that they did want to call out?
I do. Can I go ahead?
Sure.
I've lived in the house that I do live in for 7 years, and there have been many situations when I've felt really threatened by my neighbors. And first of all, when I moved in, I thought, oh, my new best friend. But the next day it's something else. What concerns me also is that, one, I want to know how to respond, or I shouldn't feel so threatened in my own household. But the reason I also feel so threatened is that she has come at me. She hasn't made contact, but she has cut down my trees, she has cut down my flowers, and I asked my husband if I had a cat, would it still be alive?
So just to, and if I get something wrong, correct me, but I want to summarize for the folks who maybe couldn't hear. So she has a neighbor who has what sounds like some issue, some mental problem, who has done some property damage and made threats that come at you and in the 7 years that you've lived in the house. And it sounds, what I'm hearing is a lot of, not only, of course, fear, but frustration, concern, and questions about your safety. Yep. Well, I have one thing that I wanted to make sure to say in response to that. Well, two, and then I'll see if my colleagues have anything to add. One is, you're never going to hurt anybody by calling the police.
Oh,
good. Good. Now, I can't speak to what their response is or how they handle it.
She's well known.
Right, and it depends on the jurisdiction. We, more than any other specialty in medicine, deal with law enforcement a lot. And I'm not going to tell you, but I could tell you, jurisdiction by jurisdiction, certain departments are better at handling this sort of thing than others. The other thing, though, is I do want to make the point, and this is not to minimize what you're telling us, but for the broader audience, I do want to make the point that it's been very well validated that sufferers from mental illness are more likely to be victims rather than perpetrators. Now, that's not to say, especially given recent events that have been in the news, several of them, that it doesn't happen. Of course it does. And as I showed you, especially if there's substance abuse involved, people can be aggressive, can be violent. We have locked psych units with security and safety measures for a reason, right? So I'm not saying that everything is flowers and bumblebees, but I do want to make sure that people understand this sounds like an atypical situation. at least from all of the people that we see. Now, it's certainly not an atypical situation for you as daily life, and that's a very, very hard thing to deal with. What other things would people want to add if you were working with either her or this person?
You know, one thing that occurred to me is you have a lot of power. You know, as a public person, if you have any safety concerns. So, if you have safety concerns for other people or for yourself, you can fill out a petition for hospitalization if there's ever a concern. If police get involved. So, if somebody, and we don't like to do this, but sometimes we have to. But if somebody has to be involuntarily hospitalized, then anyone in the general public can fill out what's called a petition for hospitalization. So it's possible, you might be asked to fill out something like that at some point.
We should have been close.
Right. So the second half of that, which is required for an involuntary hospitalization, is a clinical certificate, which has to be filled out by a physician.
My husband, about a month ago, filled a complaint. I mean, we've had police out many times, but he finally filed a complaint. And I said, I feel badly that we're doing this, but on the other hand, if we don't make a mention of it, nobody knows what's going on here. Right. And I need some help.
Right.
I mean,
well, then,
and I guess the other thing is I'm concerned about, is there that great of risk? I mean, it's not a happy moment, it's not a good moment. Why should I have to be hiding in my own home to
that's right.
avoid these moments?
Right. Now, you have a right to your safety and happiness. Your neighbor has a right to safety and happiness.
Right. And you're trying to be kind.
You're absolutely right. And I echo what Dr. Mortenson said. One thing that I think should be made clear to anybody who's faced with this is, even if this is your kid or your relative, you're not signing the person into the loony bin, okay? You're starting a process that is designed to protect their rights by documenting what's going on, and then the authorities take it from there. And like Dr. Mortenson said, nobody gets committed into the hospital without multiple doctors actually input. And so you are taking that first step of getting them to the evaluation, usually in the emergency room, usually. But after that, your responsibility, for the most part, ends. And we have this conversation probably on a daily basis in some settings, that we'll take it from here.
I got diagnosed with bipolar 4.5 years ago, and I'm on a slew of medications for depression, bipolar, anxiety, you name medication.